Good evening, everybody. Thanks so much for joining us. I am Kelly Vogt. I'm a trauma surgeon in London, Ontario, and I will introduce you to my co-moderator, Dr. Chad Ball, who's going to get us started tonight. Except I wonder if he's having some technical difficulties, so I'm going to take over. It's my absolute
No,
pleasure.
no, I'm good. No problem.
All right, fire ahead, Chad.
All right, welcome everybody to EBRS. As everybody knows, the late and wonderful Robin McLeod started this, and it was a passion of hers for many decades. A group of us have been very privileged to follow in her footsteps, and it comes in many different formats, as you know, both in person at meetings as well as through journals and these webinars. So, welcome to everybody. We're thrilled to have you. We have a really neat paper that was actually a AAST podium paper in 2023. And having just returned from that meeting this year, there was a follow-up. Maybe we can get into that at the end. Dr. Vogt, who we all know is going to talk about and introduce that paper. I'll just take a second to introduce two of our panelists, though. Dr. Tillmann is a critical care physician at the Toronto Western, as well as a burn intensivist at the Ross Tilley Burn Center in Toronto. He's also a TTL at Sunnybrook. So wealth of experience. He's been on the academic side, an associate editor for the Canadian Journal of Anesthesia for critical care section in particular for a little bit now. He comes to us from Western Ontario in terms of his medical degree. And then eventually at the end of the day, of course, is fellowship trained in all the above mentioned areas. What's really neat about Dr. Tillmann is his PhD in clinical epidemiology, which was completed at U of T as well. He really has a broad array of not only interests, but talents in terms of resuscitation, severe neurologic injuries, and really everything trauma and critical care. So welcome, and we're really pleased to have you, Bourke. We also have Emilie, who I think many of you know from previous EBRS sessions and her national footprint. Emilie still works at VGH. She's a clinical associate professor at UBC as a result. Emilie comes to us all from McGill originally, and then her surgical residency in Laval, and then trained with many of our friends at LA County USC for her trauma fellowship. I think nationally we know Emilie maybe even best for her global surgical care initiatives, and she's really a thought leader and a pretty impressive human on many fronts, but that in particular. Finally, she's the UBC Trauma Surgery Fellowship Program Director and has been for a bit. So welcome, Bourke, welcome, Emilie, welcome, Kelly. Take it away, enjoy.
Thanks so much. Given the interest in kind of trauma video review, and we had hoped to have one of the authors of an important paper in this area come on, but I thought I'd just take a minute before we get into the paper to talk about the role of trauma video review in Canada as one of the centers that's just onboarding, and the others are represented, at least some of them on this call. Just briefly to overview, the concept of trauma video review is not new. It's been in existence since the 80s, even before that in some areas. But the concept behind it is that we are recording and evaluating trauma resuscitations. There's over 70 centers in the United States, and there's, at the time that we are aware of, 3 centers that are active in Canada. As I said, in London, we are up and coming with this here as well. I should acknowledge Dr. Anton Nicoline, who helped me put some of these slides together. The concept behind it really is that if we can't measure it, we can't improve it. And really, as anyone who's ever been in a busy resuscitation bay knows, we know that we are very limited in our ability to recall what's happening in those highly stressful situations. We also know that a lot of what happens in those scenarios is not captured in the medical record. So we're left trying to direct quality improvement based on partial and often inaccurate memories of what's occurred. So when you introduce a system of video recording, it's been shown again and again that it can lead to multidisciplinary collaboration and also great opportunities for performance improvement. And there's numerous papers out there that have addressed that. In most cases, trauma video review is considered a quality improvement initiative with important consent considerations and legal implications, which we'll go into briefly. The general concept is you look at only a few people access the raw videos, and any videos are then ideally de-identified before showing them to other people and deleted in a timely fashion. I think key to this for any center that has it is an acknowledgement that TVR should not be used for punitive purposes or catching people or really for any legal recourse for it to be an effective program. And this particular paper and a few others have identified that faculty generally seem to have good perceptions of this, even though I'll tell you in my center as we started this up, there were a number of concerns that were brought forward. I think really important as you build a program, if that's in your wheelhouse, or for those who have already built their programs, recognizing the importance of the perspectives of patients and their families and the clinical team, and then also acknowledging that there is some privacy risk and legal implications. This paper really goes through them quite nicely, and though it's not the focus of our review tonight, I think a couple of important things to highlight. This paper talks about the legal lens, the ethical lens, and the administrative implication in one of our Canadian provinces in Ontario. And the bottom line is this: at least in Ontario, our current legislation is not exactly clear on where trauma video review sits. It doesn't expressly state that the personal health information captured through trauma video review is allowed to be collected, but it does not expressly state that it is not either. It also allows for the collection of personal health information with consent if it is reasonably necessary for the provision of health care. However, this specifically excludes quality of care information. And so it's challenging to know. Similarly, there's a lack of clarity around where trauma video review and other video review sits with respect to quality of care. That being said, there is broad agreement in many legal avenues that because this data is captured for quality improvement purposes, it likely is inadmissible in civil cases and would likely be inadmissible in any other legal cases, at least based on the current case law. There are important questions that arise in every trauma video review program about patient consent, with really all of the options being explored in other areas. But I think the reality for us to understand is that it is impractical for patients to consent to being recorded prior to that recording happening. And so in most centers, there's an exception that and understanding that there is some degree of risk associated with this. For the most part, I would say kudos to my group and others who are going forward with this, acknowledging that there's a small administrative or risk that comes along with it is not enough to stop the important quality improvement work. I certainly believe, as others I know, that the risk of not pursuing trauma video review is greater than the risk associated with going forward. So I will stop there just with that brief primer, and I'm going to turn it over to Dr. Tillmann to provide our methods review on the paper that we're bringing forward today. As a reminder, the chat is open for any questions that you have. Dr. Ball and I will facilitate those moving forward. I will turn off my screen so that Bourke can share, and we look forward to your review.
Well, thank you very much, and for that wonderful review of sometimes administrative challenges. I know we got our TVR program off the ground pre-COVID, and there were certainly a lot of steps that were taken by my colleagues to make it successful. Also, thank you for letting me, an emerge doc and intensivist, come crash your rounds. Hopefully, I don't see anything too controversial, and I'm happy to answer any questions I can. As far as my disclosures, I don't have any funding from private commercial interests. I do have some publicly funded studies related to propranolol and brain injuries, how we can administer TXA faster, and how people do after injury. Probably the most important thing for this paper is I am a member of the Trauma Video Review Collaborative. That being said, my membership started after the data collection that was used for this study. So I have no input into this study. It was published around the time I joined the group. So I also have no insights if you have insight related questions to discussions behind it. Understanding I'm doing the methods review, which I know is everyone's favorite part of a journal club. I have a couple key tasks that I hope we can obtain. One is make sure we have a shared understanding of why do we review methods. Yes, I have a PhD in epidemiology, so I love math. But I don't think we review methods so that you can have my love of math on display for the country. We're also going to discuss what approach they used and how does the approach taken in this study impact the way we're going to apply the results, which I'll then, of course, hand over to my colleague to talk about. So, when I think of a methodologic review, really what I'm asking myself is, did the way a group approached a study allow us to understand the truth? Because really, that's what all research is trying to do. Trying to find out, is this relationship we've studied, is what we find actually what happens in the real world? So, understanding the methods is a way to understand, did we appropriately identify the truth of the relationship? And so, when thinking of methods for this paper, the question was, if a team has better performance, do they get out of the trauma bay faster? So that's really, in a nutshell, what this paper is about. And they have applied some methods to try and answer this question. So as I looked through the paper, there were some key things from a methodologic standpoint that came out. This was an observational study. I think that probably is a no-brainer. It's hard and profoundly unethical to randomize people to having a low-performing doctor and a high-performing doctor. So you use observational evidence and rate your team performance. For this study, they used retrospective analyses. Yes, the data may have been collected prospectively for something else. This was secondary analysis. This is a retrospective study. And they used a multivariable regression. And we'll talk a bit about this. The first question, when I'm coming from a method standpoint, looking at a paper that uses secondary data, was did they choose the appropriate data set? So this is the study they looked at. It's another large trauma video review study. And what's key to know is who are the patients in this study? And they're adult trauma patients who came in hypotensive and received new vascular access while in the trauma resuscitation bay. That doesn't mean they came in without access. It's people who had IVs and needed another one, or people who didn't have IVs. And so, from a method standpoint, I think to myself, is this the correct patient cohort to use? Well, if we want to look at resuscitating sick trauma patients, we have the sick patients. It's probably not as easy or as important to see a difference between performance and outcomes if everyone has an ISS of 1 and a systolic of 120. Like, we're just not going to see a difference. So they seem to have the right patients. And the fact they excluded people who didn't need new access, I find that hard to assume that that's going to change any relationship we see in the paper. So it would make sense that this is an appropriate database to use. They use trauma video review to create this database, so it's going to have that granular evidence. The next question that, of course, comes up is the exposure, which is better performance. That's a complex statement to make. So I want to know from a method standpoint, what is better? How do we know if some team is performing better than the other team? And so for this paper, they use the non-technical skills tool that has been developed and then modified for use in the trauma bay. And this is the initial study looking at T-Notex. And it was a actually fairly complex tool. It's a score of 1 to 5 on 5 domains, which gives you an overall score of 5 to 25, with 25 being a high performing team and 5 being a low, and oh my gosh, I'm out of breath. Thinking of this from a method standpoint, you want to know how predictable and how reliable it is. And if you go back to the initial papers, you see there's moderate correlation with outcome measures. So maybe we're seeing better teams have better outcomes, but also there's low to moderate inter-rater reliability. So if three of us look at the same team, we may give them different performance scores. So it's challenging to know what we're measuring. But the TVR team, so Ryan and Dan and their whole group together, realized that this was a complex score, and in some of their prior work have actually created a simplified score. And in this, instead of having a 1 to 5 with 5 tools, they created it as 1 to 3. What's also a bit of a challenge here is they flipped it. So 1 is the best and 3 is the worst, and lower score is better. That's just important to know. So, from a method standpoint, when I look at any measurement tool, because this is a tool used to measure performance, I ask myself, what difference is really meaningful? We think of trauma. Do we really care if someone's ISS is 2 and another person's ISS is 4? Well, we tend to bin ISSs. We have like less than 9, 9 to 15, 16 to 24. We tend to create bins because, from a clinical standpoint, a 1 point difference may not be that meaningful. Likewise, when we look at T-no text, if we go back, there's 5 different categories. Are they all equally important for team performance? And I'm just not sure. And then is there a cutoff? If you have a score of 5, does that mean you're the very best and 10 is the very worst, although you could go all the way as low as 15? They actually provide some of the answers to these questions. It's just not in the methods. So I did have to go into the results section. I'm really sorry. And it shows that they decided if you had a score of 5, that was an excellent team. 6 to 10 is good, and 11 to 15 were where you had opportunities for improvement, if you would like to say. So now we know how they categorize the exposure. What was the outcome? The outcome's time. Time is, actually challenging to measure because it says how long you're in the trauma bay. And I don't know how many of you have done trauma video review, but deciding when someone comes in and when someone leaves, not as easy as you think. So they did use a standard definition. It was when you saw the stretcher come onto the screen and when you saw the stretcher leave the screen. So it's good in the sense it's standardized. This is interesting, especially from a Canadian experience. So I know there are many resuscitations where I've sort of finished everything I can do in the trauma bay, but either the OR is still prepping, so I'm sitting there, or there's a stroke on the scanner, so I'm sitting there. So just because I had to wait 5 minutes for a patient who had a stroke to leave the CT scanner, does that mean that there's a difference in how the team performed? The other question that's raised is you measure this in minutes. We know about the platinum 10, the golden hour, we know all of these things. But what's the clinically significant time difference in a trauma resuscitation? We'll see the times they looked at, but I want to know, does it matter if you're 1 minute slower, if you're 5 minutes slower, if you're 10 minutes slower? Because there is always a difference in a paper between something that's statistically different. We get a large enough paper with a large enough people, you can see really small differences. But what do we actually care about? The final thing to think about from a looking at their methods section standpoint is how did they address confounding? We know this wasn't a randomized trial. We know that's not possible. So we know that there will be different patients in different groups. So they used a linear mixed effects model. I love when we use all these terms. But basically, what they're saying is they adjusted for differences in patient characteristics and they accounted for the fact that people have similar outcomes at same hospitals. That's why it's a mixed effect. The challenge here is the outcome is time, and time outcomes are weird. When we think of data, data is either normally distributed or skewed, and time is almost always skewed data. What do I mean by that? I mean that most people are going to fall in a box, usually like a trauma resuscitation, 20, 30 minutes. That's where you're going to sit. But there's going to be a couple people, for whatever reason, it takes a long time. Maybe you started with a left lateral thoracotomy, had to convert to a clamshell. Maybe you started with Reboa, then you converted to a thoracotomy. Like there are reasons that there are going to be these outliers. To analyze skewed data, unfortunately, the assumptions of a linear model don't fit. And that's where you switch to non-parametric models. It's a Poisson regression if you want to know the name. You can also use a negative binomial. The idea here, though, is if you use a standard distribution model, a linear model, you're more likely to find a significant association when in fact one might not exist. They included some important confounders, at least what they said was important. So things that's related to performance and to outcomes. And we can decide as a group if we think they are the right, the wrong, if they're missing things. And then For the exposure for their performance score, although they said 5 is excellent, 6 to 10 is good, 11 to 15 is poor, they use it as a linear scale. So they want to look at every 1 point change. And again, we can discuss about the sensitivity there. The last couple things I'll talk about from a method standpoint, because this does touch on the results, I'm not going to go in deeply, is they show that they didn't include people who died. That being said, I find it hard to say that there's going to be a difference in the relationship between team performance and time by excluding death. We may see a difference in the relationship between team performance and mortality, one of their second outcomes, because they've excluded death. But time itself, harder to say this is going to change it. When I'm thinking of external validity, I want to understand how these patients represent my patients. Well, these are the characteristics they gave us in table 1 and 2. So maybe this is enough characteristics to compare to our teams. Maybe there's more things we want. And they did realize this was skewed data. As you note, they use medians for everything. So their time to the next phase is done in a median. And you can really tell the data skews because the median time is 23.5 minutes. But the quartile ranges, they're not evenly split around it. And you see that it's starting to have some tail end long stay patients. The upper end of the interquartile range is 35 minutes. So we know it's skewed data. And then they present their adjusted outcomes. I like to only see the key variable. Their sort of mental model wasn't designed to look at their confounders, they're just confounders. But this is what they give us. And of course, we can talk about it in the results. But sort of my thoughts from a methods and from someone who uses TVR. TVR is a good way to capture performance data and other things that just are not written down. You get a lot of increased insights and you can avoid some of the biases. And there's lots of avenues for improvement. But when we're looking at the methods for a paper, we have to understand that the model we choose can impact statistical significance. And that unfortunately changes the way we interpret the paper. We want to ensure that any outcome we're doing has significance to us as the clinicians using it. And also, we understand the exposure. What is improved performance? What does 1 point change mean? And then when you have findings, if better is faster, well, how do we apply that? Can I just sit in the trauma bay and yell at my residents to be better? I feel like that's maybe not the most effective teaching skill, but are there maybe some insights as we look into the secondary analyses about what parts of performance and where should we actually start to focus our improvement initiatives? So again, I wanted to thank you all for having me be here. And of course, I'm happy to answer any questions that you may have about the methods and always chat further about trauma video review, either in person or via email.
Thank you so much, Bourke, for an enlightening review. We'll turn it over to Dr. Joos now for our clinical review. Just a reminder, please put any questions you have in the chat and we will get to them once the clinical review is completed. Looks, Emilie, we see your presenter view.
Oh, I don't want that. Why is it always so hard?
I don't know. It shouldn't be. I agree with you.
Oh my goodness. Hold on. Let me stop this. I don't even want to use the presenter view. This. How do I do this? Sorry, guys. It should be easier.
I was working before and then it doesn't work when you're in the middle of it. It's the way it goes.
Yeah, exactly. Okay, so if I do the whole desktop and I do this, does it work? No?
Same. If you want to flip it to me, I can show it for you.
No, it's okay. There has to be a way to, I don't want presenter view. I want nothing.
Looks better. Good
Does it
enough.
work now? Is it good enough?
Good enough.
Okay. Good evening, everyone. Thank you for the kind introduction. It's a tough act to follow. I am not a member of the TVR consortium investigators, so I will speak from kind of a newbie in this world, we are currently trying to implement video review in our trauma bay at Vancouver General Hospital. The last obstacle in our way right now is funding. We potentially can talk about that at the end of the hour today, but we're getting there. As Dr. Vogt mentioned, trauma video reviews have been there for a very long time, and they're increasingly popular in North American trauma centers. It's now formally implemented in 30% of US level 1, level 2 centers in Canada, in Toronto, as we mentioned. And it's been shown in multiple studies to outperform in-person prospective data collection, so a way better and more accurate way to demonstrate errors or potential for improvement in trauma resuscitation, which we know are very fast-paced. So the author's hypothesis was that a better team performance in a trauma bay would be directly associated to less time to the next phase of care, meaning less time in a trauma bay and potentially faster time to hemorrhage control in the operating room, for example, or IR, or faster time to diagnostic imaging, such as CT scan. As mentioned previously, this was a retrospective analysis of a prospective multi-center database of 19 US and 1 Canadian trauma centers, Sunnybrook, and the videos were recorded between May 2021 and May 2022. They used pretty standardized definitions, and I like how clear it was described in terms of phase of care. Wheels in and wheels out was a definition of a patient basically entering, exiting the phase of care. So as the trauma stretcher was wheeled into the trauma bay, it was stamped as the time of patient arrival into the trauma bay. And as the wheels were last seen exiting the trauma bay, it was stamped as the patient entering the next phase of care. In terms of time to blood transfusion, they use the definition as seeing blood in the blood tubing and not as the TTL or any other member of the team ordering blood. So it was basically as the blood was actively being transfused into the patient. The population of this study is adults, so over 16. And all patients that were hypotensive, so systolic less than 90, on admission or within 5 minutes of their admission to the trauma bay. They excluded, as mentioned, patients who died in trauma bay and the patient who they were not able to complete the T-Notex variables on. We've been through this before. This scale has been there since 2012, and they simplified it as much as possible to be able to be used in such fast-paced environment as a trauma resuscitation. So 5 categories: leadership, cooperation, resource management, communication, assessment, and situational awareness. And very important to note that the lowest score is the best performance, the highest score, which is 15, is the worst performance. So looking at our results, I think it's important to emphasize, as it was before, the types of patients that were included in this study. So they were young patients, median age of 42. They were mostly male, and there was a very high proportion of penetrating trauma patients. So we can imagine that's a little bit different than our patient population here in Canadian trauma centers. The mortality was high at 29%, and 26% were directly to the operating room, so a quarter of patients. Interestingly, too, in terms of the mechanisms, as 39% were penetrating trauma, 26% total, so a quarter of these patients had penetrating thoracoabdominal injuries. Okay, looking at the results now. So they broke it down into basically the resuscitation piece and then their primary outcome, which was the time to the next phase of care. So in terms of trauma team composition, most of the time the trauma team leader was male, 57%, and attending in 53% of the cases. The median number of trauma team members was 12, with a range of 10 to 15. Looking at the T-Notex score overall, almost half of all of the teams reported in those 19 trauma centers scored 5, which is excellent. That's your perfect score on a score of 5 to 15. So almost half of those teams scored a score of 5. Good score 6 to 10 was 43%, and only 9.5% of teams scored a low score where there's room for improvement or considered a poor team performance. Like I said, the overall median size of the teams was 12, and in terms of association between the trauma team size and time in the trauma bay, they determined, and sorry, association between the team size and the T-NOTEX score. There was an association between the T-NOTEX score and the number of team members. So the best teams, so the highest scoring teams, had a median team number of 10. And the poorest performing team, so the highest scores on the T-NOTEX scale, had a median team numbers of 13.5. In terms of mortality, overall high mortality of the whole group, 29%. They could not find any association between the overall T-NOTEX scores or subset scores of the 5 categories between the team performance and patients' mortalities. So between the 3 groups, where the teams were excellent, poor, or good or poor performing, the mortality was the 3 numbers you see here, so between 27% and 33% with no statistical significance. They then did some unadjusted analysis looking at the association between T-NOTEX score and the time to next phase of care. So overall, the median time in a trauma bay across the study was 23.5 minutes. The best teams had a performance of 20.7 minutes in the trauma bay, which is 7 minutes faster than the worst performing team. So you can see here in table 3, that's the unadjusted outcome measures by the T-NOTEX team performance score. And you can see in the first column, best team performance, 20 minutes, and the worst team performance, which is a poor team performance, at 27.8 minutes. Still, the unadjusted results here, the figure 2 basically breaks it down by T-NOTEX total score. So you can see 5 to 15 there. And there was a correlation between the T-NOTEX total score and the time to the next phase of care. So I'm sure that Bourke can explain this figure way better than I can. But as you can see here, there's a few outliers. The association is not linear. So of course, the best performing teams have a faster time in the trauma bay, as you can see here in the first part of the graph here, with the score of 5 and the lowest time in the trauma bay. And yes, the time seems to increase in relationship to the increasing T-NOTEX score. But for example, teams that scored a score of 12 had also a pretty short time in the trauma bay. So this is not a completely linear relationship, but it is an association. In terms of adjusted analysis, so they adjusted for all the variables that we talked previously about. Their major, like the bottom line in front, the big result of this study was that for every point worsening on the T-NOTEX score, so that's basically out of all the 5 categories, that added 1.6 minutes in the trauma bay for P that was statistically significant. And broken down by those 5 categories, so 4 out of the 5 domains were associated with faster time. So that was true for leadership, for communication, for assessment, and for situational awareness. The only category for which it was not shown as a direct association was cooperation and resource management. Here are the graphs associated with that were shown previously. So if you look at the total score in figure A here, everything that's red is statistically significant. So the T-NOTEX total score is statistically significantly correlated with decreased time in the trauma bay. In terms of secondary outcomes, they looked at the time to blood transfusion, which was also an adjusted analysis. There was no difference there. The best and the poor performance team had a time to blood transfusion of 7 minutes. They did a multivariate modeling, which showed that on its own, the category situational awareness provided basically, if the score was better in this category, a faster completion of blood product by 4 to 5 minutes. They also did a subset analysis looking at patients who went directly to the OR or IR. That's 82 patients out of the 441. And showed that for each point worsening in the T-NOTEX score, it added 2 more minutes in the trauma bay, but this was not statistically significant. So to summarize the results of this study is a large multi-center trial looking at 19 trauma centers in the US and Canada, 441 patients who were all hypotensive, so extremely sick patients with up to 40% of penetrating injuries and a quarter of them thoracoabdominal injuries. This study described very large trauma teams with a medium number of trauma team members of 12. And then for every point gained in the TNOTEX score, the time in the trauma bay was decreased by about 1 minute. Overall, there was no difference in mortality or time to blood transfusion. So in terms of the interpretation of this work, I think it is an impressive body of work in terms of the data collection, the quality of the definitions, as well as the use of the TNOTEX scale, which has been reproduced in multiple other studies and seems pretty valid. Overall, like in terms of their results, the teams were fast. And if you compare, like it's explained in the discussion, but I think it's a nice comparison to a recent ACST-QIP analysis, which looked at patients with gunshot wounds to the abdomen requiring immediate OR. The 75th percentile of trauma teams basically spent 48 minutes in a trauma bay prior to the next phase of care. These teams there had a median number, like minutes in the trauma bay of 23 minutes, which seems pretty fast, so potentially difficult to find any improvement in time to next phase of care in such high-performing teams. I would hypothesize that you may see stronger effect if you looked at patients with complex blunt polytrauma, where you will see multiple specialists involved, so potentially a chaos in terms of other external stakeholders coming into the trauma bay, difficult decision making, which might increase problems with communication, cooperation, patients who would require potentially prolonged massive transfusion over periods of minutes to hours, and patients who may experience multiple events where they have change in clinical conditions requiring situational awareness and change in plans and really proper leadership of the trauma team. Overall, I think it's a key method in terms of quality assurance and improvement within all trauma centers and should be implemented where logistically and financially feasible in all our trauma centers. I think it's really the best way to identify room for improvement and should be applied, like I said, to a larger trauma patient population. I'll stop there. Thank you.
Thanks to both of you for really tremendous reviews and really diving deep into this important paper. Just a reminder to please put any questions that you have in the chat and to fill out the attendance form to make sure we can get you your CME credits. Chad, I might start by asking you to just elaborate on the kind of follow-up that you saw at AAST, hot off the presses for those of us who weren't able to attend.
Yeah, it was an interesting discussion. So they looked sort of further out. I want to say their median follow-up was 12 months or close to it. And they found that there was actually improved long-term outcomes that matched the initial experience in terms of their patient trends. It was very, very interesting. The other thing that, it sort of came to my mind as you were presenting the introduction is that back when I was a trauma fellow in the US, I remember starting and we had trauma video review, and there was a lot of places in the US at that time that had that. And then the government changed, Congress changed, and they passed a law that essentially made it illegal because of many of the subtleties of the Privacy Act that you brought up. So we had it for a few months and then it went away. And obviously that law has been reversed. But I'm curious both what you and the rest of the group think in terms of the true exposure in terms of risk here of doing this. I think all of us obviously have a vested interest, but I'm not sure if we were sitting in front of a mixed, hospital or healthcare system board with, laymen and lawyers and everyone else that usually sits on those boards, if they would see it the same way.
I'm happy to start as a representative of a center that has, after 3.5 years, gotten through those administrative hurdles. I know, Bourke, it was kind of a little bit before your time at Sunnybrook, so you may not have had as much insight. But I think you touch on the most important part of it, Jed. Like, it's really about getting people to understand the vision and getting people to understand the reality and the practicality of this quality improvement tool. You know, the research is amazing that comes from it. And I completely agree with what Bourke said at the beginning. It's really the only way, and Emilie too, really the only way to be able to capture in real time what's happening. But, and I know this is EBRS, but I think the benefit for that at an individual system level, my hospital level, your hospital level, is that it allows you to identify and act on targets for quality improvement so that at the end of the day, you're improving the care that you provide to the trauma patients that come through your doors. I had the opportunity to speak to a number of lawyers throughout this process, and while their perspectives all differed, they all agreed on one thing, which was that the current legislation has not caught up with the innovation. And so the legislation is grossly inadequate, at least in the perspective of the lawyers that I interacted with, to be able to address the role of video review in healthcare quality improvement. It's absolutely imperative that we focus on patients' protection of their personal health information. And the truth is that we also focus on the protection of the information of our colleagues. But in my perspective, there is a way to do this with minimizing access, short retention times, and lack of punitive intent of this program that takes what is ultimately a regulatory risk, in my opinion, and turns it into something that you can swallow for the greater good of the trauma patient. Bourke, Emilie, other thoughts?
Yeah, so although I wasn't the one leading development of TVR at Sunnybrook, I was there through the whole thing. Um, and like I appreciate people's concerns, but I think there are many reasons why this is beneficial and also why our concerns may be a bit overblown at times. We accept that we can literally cut patients and cut parts out of people and store them for their care, and we can document and write down literally everything about them. And if you read any of the notes, they will discuss what the physician did as well. There are many notes I've seen that say what I did, and that's totally fine. And this is the more accurate way to do it. So people are still writing down what we do, and that may be inaccurate, and this is the more accurate way to do it. It's also kept in a very secure way, likely more secure than a lot of our paper charts, which have been found in many locations, whereas this is kept on a secure and locked server. So I very much appreciate and understand why people are concerned about this. I don't want to belittle that at all. I think it's likely the next phase in how we chart on our patients. And this is going to continually be incorporated. We just didn't have the technology beforehand, so we had to sit down and secondhand all this stuff, and now we have the technology to do it. Um, so whereas yeah, there's lots of reasons why people are concerned. We can do this safely, and we for sure improve the care provided to our patients. And we already write down everything we see and do and keep parts of humans in frozen sections in our hospital. So I think we should figure out the way to make sure we do this safely and we will provide better care for our patients.
I'll just add one thing, Kelly. I feel like times are changing, and maybe thanks to the advocacy as for, people like yourself and Bourke and all the teams who have worked really hard to fight for the dissemination of this type of tool. But our lawyers here at VGH were actually way nicer than yours. And what they basically asked about is to ensure that we mitigated the risk to the hospital and to the staff. The 3 points that we had to specifically address in our policies and procedures was ensuring data security, make sure there was no, possible breach of that at any point, patient confidentiality, of course, and that's what we do in the hospital every day. That's just our jobs. but as well as staff wellness, and that's something that we have to take into consideration. As anybody can be caught on tape doing something, and people have to feel safe that nothing is going to be held against them, or I'm not necessarily talking about it in the court of law, but it could be as a colleague or as a team member outside of the review itself. So apparently I was not part of those conversations directly, but as the team or my team said, it was not the biggest hurdle. Yeah, sorry, Bourke and Kelly.
No, that's super interesting. I want to come back to your biggest hurdle in a minute, but go ahead, Bourke.
So the question about team wellness comes up all the time. So we presented how we established our TVR program at TAC, I think 2 years ago now. It was when I was in Edmonton, so I can tell you that. And anyway, and we had the same concern, and our data shows from our own teams because we do monthly rounds where we review the videos, and you will see in the first year people are very worried, and our comfort levels and the pride in the program has increased. It's sort of at the point where it can no longer increase because people are very comfortable with it. So it's a hurdle that I do not think any program has not had to address. But the evidence that we have locally and the evidence that you see sort of coming out is that as people do this, they see the benefits to their patients. They understand the way it's run is not a punitive system, and people actually take quite a lot of pride in it. And that was one of, I think, the big things that we wanted to present at TAC when we talked about this, because for sure that is a hurdle that has been addressed and raised.
That's super important. I'm getting questions by text, so I'm going to ask you a few of them, which was, whose trauma center has 12 people on the trauma team? Do either of yours have 12 people that are regularly attending? And I'll start by saying only at noon or the middle of the day is that what my trauma team looks like.
Did they count the RNs in the trauma team response on this? I can't remember off the top of my head.
It wasn't clear to me from reading the paper, so I assumed they had to be counting the RNs. But I have 3, and I have me and a resident and maybe another 2 residents, so that doesn't add up to 12. But maybe it doesn't in Toronto.
So if we count everyone in the room, it will be a trauma team leader, a sub-trauma team leader, a gen surge resident, an ortho resident, an anesthesia resident. If it's a level 1, they'll also be either the trauma fellow or the trauma staff. We will have 3 nurses, an RT, and X-ray. So we'll have 11, even in the middle of the night, and during the day it will be bigger.
Cool. Christina, I don't know if you're going to be able to talk, but try and unmute. If not, you're going to have to. Oh, there we go. We got you. Go ahead.
Thanks. Sorry, the chat's disabled, so I couldn't reply in the chat, it seems. But I'm one of the trauma fellows at St. Mike's, also in Toronto, and I would say like we easily hit 12 on most activations as well, even for like what we call tier 2s, like less acute activations where the patient's stable. For similar reasons, like you have like 5 different physician teams, and there's a TTL and a sub TTL, so easily hit 12 even in the middle of the night.
Thanks so much for that. I do not know how to undisable the chat. So if our EBRS staff can help do that, that's great. And if that doesn't work, obviously people can speak. So go ahead and put your hands up. Emilie, what about at VGH?
Yeah, for sure. Middle of the night, we are only 1 junior resident, 1 senior or fellow, and the attending, that's 3 people, and the 3 nurses. So we probably would do the best. We would do like 18 minutes. But middle of the day, it's bigger. I feel like it gets very chaotic above 10. So I really congratulate the St. Mike's team for performing well under high volume trauma team members.
I think it's very interesting because intuitively, and I suspect you both agree, the more people you have in the room, the less efficient and the more challenging it becomes to, more is not better. There's a critical mass, but once you exceed that critical mass, how about the foothills, chat?
Yeah, Calgary's a disaster. We tracked that for almost 6 months. We had an average of 23 people on a level 1 activation, so our top tier activation. And that includes, relatively low level learners kind of standing there looking at it all the way through all the RNs and crowd control has been a big problem here in Calgary for a very long period of time. I would echo your comment very strongly that when you train, work, or visit extremely high volume centers, say the top dozen or so on planet Earth, you might have, 4 to 8 people with gunshot wounds and stabbing side by side by side. And usually there's 1 or 2 people at each bed, and it's very quiet, it's very organized, it's very maybe routine. And I think that's what we struggle with really across the board in many less high volume places. Obviously, that applies to all of Canada, really. That there's a fair bit of voyeurism, for lack of a better term. And I agree with you entirely. That can lead to major communication errors, ambient noise that's really non-functional, very poor efficiency, and I think really would lend itself to trauma video review. I think that would be so obvious with the sound turned off, just looking at a screen with 12 to 23 people in it. It'd be a problem, and it'd be pretty evident pretty quickly. It'd be helpful.
Absolutely true. Although, you bring up a different point, and we're going to move on from this, but the educational aspects of it in these centers. We talked before about HALO, the high acuity, low occurrence events. It's very challenging to figure out how to train in that paradigm. There is a question in the chat now, so thank you to the EBRS team for fixing that. How many hospitals are doing video recording in the OR, which is what I would like to do in our very small hospital? That's great, Ken. I will let my colleagues comment, and then I can comment too. Emilie, are you guys doing video review in the OR?
No.
Bourke, Sunnybrook? Yeah, the only I don't Chad, Calgary?
No.
They're doing it very routinely in St. Mike's, and I know this because the St. Mike's group was very supportive of us as we navigated some of our legal challenges, and they did have a long period of time where they were consenting, and now they've transitioned even away from that for the trauma video review that's happening in the operating room. I don't know if anybody else on the call can comment on their hospitals, but that's the only one that I'm aware of that's routinely using it. But I commend you for doing it, because I think the challenges are the same. The only advantage that I would say you have as you navigate the challenges around the legal and ethical implications is you can consent patients for that for the most part. You're consenting them for surgery, most patients, and so that's an opportunity to consent for the recordings, which makes the whole process, I think, much, much easier. I had one more question that I got by text, which is, how do we feel about the fact that they excluded all the patients who died in the trauma bay? Bourke, I thought you maybe had a thought about that based on your methods review, so I'm going to let you go first.
Sure. So it comes down to what outcome they really were focused on. So their outcome focus was time out of the bay. I, in my methods review, ignored the secondary outcomes. It makes the mortality analysis useless, unfortunately. Because the challenge comes down to someone who dies in the trauma bay. There's a number of reasons. One, they may have come in with a non-survivable injury, and does not matter how efficient your team is. But also, if we think, where is a upfront intervention going to have the highest impact? When the person dies right there. But because the question was, how long does it take them to leave? Someone who dies never leaves. So it's just not data you can work with. So I don't think it impacts the relationship between time and trauma bay and outcomes. But of course, the reason we care about time and trauma bay is how does it improve outcomes overall for patients? So if they were truly focused on mortality, if they were focused on those type of things, I think it would be a fatal flaw to the study. But because the study wanted to look at how long it's taking to get out, I am nowhere near as fussed. I haven't seen the paper they presented this year, Chad, but I hope they use the initial cohort that was used in the Moving the Needle study. And if they use the entire 500 and some odd patients to look at long-term outcomes, then you don't actually have that issue anymore. I just don't know what population they used for that study.
Yeah, same group. Good question.
Chad, did you have any other questions for our panelists?
No, I don't think directly. I think you guys, from my point of view, hit all the relevant topics, on the head. I think, again, this topic in general just screams for two things. One is an honest look at your own environment and asking that question, given your volume, given the expertise around you, given a need or a lack thereof for quality improvement. Is it worth pursuing this? I would hope most of the answers are yes. And then the other part of it, which we've kind of beautifully danced around and briefly touched on, is that the humility component that comes with this kind of care. And I think if you're being humble and you're being respectful and your goal really is to improve trauma care, it's very difficult to make a contrarian argument to this sort of educational and quality improvement endeavor, really, in all of our institutions.
Yeah, I think that's amazing. Bourke.
One other plug related to developing trauma video review. So as a collaborative, we are in the process of finalizing a standardized data collection kit. So think of it similar to TQIP or NTDB or any of these other ones, and are programming that into REDCap. So the manuscript has been submitted. I can't talk much more about it clearly, but just thinking, as has been sort of flagged, the heavy lifting up front, understanding how to do data collection is also a challenge. And part of the collaborative is trying to relieve that challenge as you're developing your own video review programs. So that resource, if everything stays on track, should be available for people in the coming months. Clearly with no cost or anything. So just as a little plug for support for people developing their video review programs.
Amazing. That's incredible news. Okay. Not seeing any more questions. I think we'll conclude there. Dr. Tillmann, Dr. Joos, thank you for your incredible reviews and for joining us tonight on EBRS. Chad, Dr. Ball, amazing to co-host with you as always. We look forward to seeing you all for our next EBRS session. A reminder to complete the survey in the chat to obtain your MOC credits. Thank you, everybody. Have a safe week.
Thank you, everyone. Have a good night.